From time to time in emergency medicine, it becomes necessary to provide external support of breathing in persons who have difficulty with breathing, are in full respiratory arrest, or while undergoing surgery. A balloon-cuffed endotracheal tube, the gold standard for intubation, is usually placed through the mouth or nose into the trachea or windpipe to provide protection from inhaling stomach contents or mucus. The external end of the ET tube is then attached to a ventilation device. Intubation is a primary component of resuscitation, and time is of the essence when intubation is needed. Achieving rapid and correct intubation in the field, under all conditions and with all types of patients, is difficult at best. Of the roughly 17 million intubations performed in the U.S. each year outside of the hospital operating room, up to 20% are missed. That is, there is misplacement of an endotracheal tube into the esophagus instead of the trachea. Anatomic variations between persons make intubation more difficult to learn and perform than it may seem. When intubation is missed, this must be recognized and the tube must then be removed and reinserted correctly. Failure to recognize a miss can be disastrous. The SCOPECO Laryngoscope may reduce errors by improving speed and accuracy of routine intubations in the field, in the emergency room, and in the hospital operating room. It may also decrease risk of accidental injury during intubation, and it has a new easy-to-use design and may have improved cost-effectiveness. The SCOPECO Laryngoscope was developed by emergency physician Elroy Cantrell, DO, PhD, with the intent to improve speed and accuracy of routine intubations. The SCOPECO Laryngoscope is used to assist in placement of an endotracheal ET tube into the trachea of a patient, thereby creating and maintaining a clear airway and assisting in proper airway management. The device itself does not remain in the airway or mouth after the endotracheal tube is positioned and secured, and it is easily removed as soon as the ET tube is placed. Features of the SCOPECO Laryngoscope include a familiar feel with new functional features. The straight, rigid blade is lightweight and constructed of black ABS plastic to decrease glare. An ergonomic easy grip handle provides good directional control. A removable LED light cartridge gives brighter light. The blade tip is configured for gentle elevation of the epiglottis from above or below. The flange sidewall runs full length of the blade to completely deflect the tongue out of your viewing channel. The wide lower flange extends full length and has an upslope at the distal end to help deflect an ET tube tip into the glottis and away from the esophagus. The curved underside of the flange tip slides easily along the hard palate during insertion. The right side flange edge retracts the right upper lip to improve viewing and access. The underside of the lower flange has compliant padding to decrease risk of tooth injury. The C-channel design allows for easy removal of the laryngoscope without disturbing the inserted ET tube, and an optional splash guard / magnifier is for the user's convenience. The SCOPECO Laryngoscope is inexpensive to use, employing inexpensive standard endotracheal tubes, the gold standard for airway management. The SCOPECO Laryngoscope is available in 3 sizes: adult, youth and small adult, and infant and newborn. Overall design features may increase speed and accuracy of intubation. Indeed, the learning curve is steep and it's easy to use. That means less fear, more confidence, more competence. Throughout development of the SCOPECO Laryngoscope, our design concepts have been tweaked and validated by many professional and amateur volunteers. Let's go through the steps described in the package insert. First, prepare ahead before intubating. Assemble supplies and equipment and check for the integrity of the parts. Oxygen source, bag valve mask, medications for sedation and muscle relaxation, gloves and mask, water-based lubricant for ET tube and laryngoscope, endotracheal tube of desired size, stylet for ET tube, retainer for ET tube, 10 milliliters air-filled syringe to fill the balloon, and laryngoscopes of proper size. Test the LED lamp by opening and refolding the blade handle. The tab should be intact. Inflate and deflate the ET balloon. Insert the stylet into the ET tube to appropriate depth. Bend the distal 3 to 4 inches, about 30 to 45 degrees. Apply lubricant to all 3 sides of the blade and flange and to the ET tube. Have a retainer and ventilation supplies positioned and ready for use. Medicate and hyperventilate as needed. Remember, before intubating, apply water-based lubricant to the blade, flange, and ET tube. While holding the handle in your left hand, tilt the handle forward and hook the upper blade tip on the lower teeth and open mouth. Insert the blade tip into the right side of the mouth, deflecting the tongue to the left. Allow the curved tip of the lower flange to glide along the roof of the mouth during insertion, directing the tip toward the larynx or Adam's apple. Continue insertion with rotation of the laryngoscope as the blade enters the pharynx. Pause when the yellow depth marker reaches the right side of the upper lip. Look down the channel of the laryngoscope. Locate and identify the glottis, arytenoid cartilages, epiglottis, and vocal cords. Advance, retract, lift, or tilt the blade as needed for good visualization. Lift the epiglottis if needed. Align the tip with the glottic opening such that the lower flange tip partially blocks the esophagus, which lies below the glottis. Looking down the channel, note the large esophagus opening below the glottic rim. Avoid placing the ET tube there. Gentle downward force on the larynx by a helper can improve visibility. Under direct visualization, insert the ET tube tip into the right side opening of the channel and advance the tip into the glottis and onward between the vocal cords. When the balloon is about 1 inch beyond the vocal cords, secure the ET tube with your right hand while removing the laryngoscope outward and leftward, then remove the stylet. Inflate the balloon while holding the ET tube secure. Give puffs of air or oxygen while listening to both sides of the chest and upper abdomen to help confirm proper tube placement. When proper placement is reasonably assured, secure the ET tube with the retainer strap or other device. Sometimes position or anatomy make visibility poor and alternate techniques are needed. One such technique is to employ the Eschmann stylet, also called the gum elastic boogie. The slim rubber-coated stylet is inserted into the glottis and trachea first. Accuracy of placement is indicated by moving the stylet back and forth while feeling the tip drag across the bumpy tracheal rings. While the stylet remains in place, the ET tube is threaded over the stylet and pushed into the trachea an appropriate distance. After balloon inflation, the stylet is removed, confirming puffs provided, and the ET tube is anchored with a retainer. Useful signs of correct endotracheal intubation. 1. Bilateral breath sounds in left and right chest during puffs. 2. Absence of stomach gurgling or distension during puffs. 3. End-tidal CO2 is good. 4. Fogging of the inside of the ET tube during breathing. 5. Vacuum bulb testing device fills quickly with air. 6. Good skin color. And 7. Tube tip is about 1 centimeter above the carina, as seen on a chest x-ray. Now let's see a demonstration in real time. First, adult. Then, newborn. There you have it. SCOPECO.
Okay, Doc, that's a wrap.
Okay.
Thank you, Doctor.
Oh, quite right.
It really looked easy. Is it hard to learn how to do an airway tube?
Well, you know, that really depends on a person's inherent skills and training. The old Miller and McIntosh blades were a little more difficult sometimes depending on the anatomy, and if a person had some problems with it, it made it more difficult, and they might really miss the intubation. We think that the lower flange makes a big difference on ease of intubation, so that a person would be able to get it right the first try.
It's so easy, even a kid could do it.